Hi everybody, this is the second recording and we will start with atrial dysrhythmias. Atrial dysrhythmias include premature atrial contractions, also called PACs, atrial tachycardias, those include supraventricular tachycardias, paroxysmal supraventricular tachycardias, and paroxysmal atrial tachycardias. And then we will discuss atrial flutter and atrial fibrillation. Now, what all these dysrhythmias have in common is that they do originate in the atria. So when we're looking at PACs, they're also called APCs sometimes, these originate from an ectopic focus in the atrium, but not the SA node. So somewhere in the atria, a group of cells have decided that they want to get involved in the ability to generate an impulse, that automaticity thing. Usually, PACs are benign. Sometimes they happen just before someone goes into a paroxysmal supraventricular tachycardia. Here's an example. Let me get a better pointer. Maybe I will do yeah. And I got to find a color. I'm getting a pen. Okay, so if you look at this tracing, you can see that you have P, then you have QRS, and then you have T, and then you have another one, a reasonable distance. And then if you notice here, you can see that this complex is early. There's the PQRST. It does have an atrial origin because you can see the P wave there. That wasn't a very good circle. I would have liked for it to be smaller. And then following a compensatory pause, there is typically following a PAC, there's typically a compensatory pause. And so you can see that there's that irregularity. And then the rhythm starts kind of normally again. And here is another early beat. So premature atrial contractions are early. They have a P, QRS, T, so they do generate a pulse. If you're feeling the patient's radial pulse at this time, you might notice that that occasional irregular beat, the early one, might be a little bit weaker because the ventricle didn't fill as full. It didn't have quite as much time because that impulse was generated. Now, paroxysmal supraventricular tachycardias or paroxysmal atrial tachycardias. There is a slight difference between the two, but it's probably not real impressive for your purposes. If you take the words apart, paroxysmal means sudden onset, may also include sudden cessation. Supraventricular, supra means above. So the impulse is generating from somewhere above the ventricles. That could include the AV node in the junction area. Tachycardia means an atrial rate greater than 100. And really, the only difference between PSVT and SVT is that in the paroxysmal, you can actually see it begin. So we call it SVT unless we see it start, where the patient has a normal heart rhythm and all of a sudden they go into this supraventricular tachycardia. Then we call it paroxysmal. Now, in the paroxysmal atrial tachycardias, the origin of those very fast beats is clearly in the atria because, we can see P waves. In PSVT and SVT, we're not sure. So there's an umbrella term, PSVT and SVT, and one kind of SVT is a paroxysmal atrial tachycardia. So the SVTs, the PSVTs, those could be originating in the junction or they could be originating in the atria, but we can't say for sure. The duration of these rhythms can vary. They can just be a few beats, or they can actually last for several hours. Now, when we talk about atrial fib, we could also call that a supraventricular tachycardia, because when AFib is going very fast, it can be hard to see the trademark irregularity of AFib. So we call it supraventricular tachycardia, and then if we're able to slow the heart rate down, then we can actually see this AFib. So, what can cause these tachycardic rhythms? Well, it could be emotional stress or overexertion, sometimes just stimulants in a healthy heart like caffeine, or it could be a reentry phenomena where there's something in the conduction system, a channel that's allowing that impulse that's triggering the bundle branches to slip on back up into the atria and re-trigger. Various heart disease can also be implicated. Heart rates in PSVT can range anywhere from 140 to 180. They can be very fast. PSVT can even be triggered by something rather insignificant like a position change or a deep inspiration. Reentry pathways. In a reentry pathway, what you're looking at here, this is representing the repolarization, depolarization waveforms. These are not ECG waveforms, okay? So what happens, this is normal where the impulse comes down and goes through. Here, if there's a block in one way, then the impulse goes another way and can get back and produce a cyclical, circular kind of motion. You can see it there. Another thing that can occur is an abnormal accessory pathway outside of the normal conduction system. If you look here, here's the SA node, and it's sending the impulse to the AV node, and then the impulse goes through. And there's a couple of examples. So then here's an accessory pathway. This is the bundle of Kent, and some of the impulses get through and they trigger the bundle branches through this way, and then in the process they come up backwards to the AV node, producing a cycle. Here's another local reentry example, just where it goes in circles. Sometimes the impulse goes through the AV node and it can come up this way and go in circles. Here you go. Here you can see the SVT. See how fast that is? And when I look at it, I don't see P waves. All I see is QRS, T, QRS, T. Now they're calling this a paroxysmal atrial tachycardia. To me, I would not be able to call that an atrial tachycardia. I would just have to call it SVT, because I really can't tell that it's coming from the atria. And then here you can see where it slowed down, P, QRS, T, P, QRS, T, P, QRS, T. Now, is this a T wave or is this a P wave? I think it's a T. But I'm not sure. Here, this is PSVT. You can see where it was normal, and then suddenly it triggers, and you have this very rapid rate. Now this I can appreciate as atrial tachycardia. This is not hard, because here's my P wave, QRST, P, QRST, P, QRST, P, QRST. So this is atrial tachycardia. I'm good with this. This one, I would just call that SVT. Now what do we do for SVTs? Well, we're going to treat the underlying cause. First of all, we're going to determine what the impact of this rhythm is on the patient. And then we're going to support the patient as needed. Sometimes these heart rates can be so fast that the ventricles are just not having time to fill, and the patient can become very hypotensive. Underlying causes for SVTs can include hypovolemia. So, sinus tachycardia can be an SVT, and sometimes it can happen so fast that you can't tell that it's actually originating in the sinus node. And generally, when we say supraventricular tachycardia, we don't think it's in the SA node. We don't think it's originating there. It's originating somewhere else. But the umbrella term for SVTs does imply or include any tachycardia that originates above the level of the AV node. So just sinus tachycardia would also be an SVT. So looking at these underlying causes, some of the electrolyte imbalances, calcium, potassium, magnesium in particular, thyroid hormones in excess, some medications can produce these problems. What we can do first and foremost is Valsalva maneuver. A vagal or Valsalva maneuver. Have the patient cough very forcefully. That can trigger the vagus nerve to pull the reins on the situation a bit, or have the patient bear down. Then there are some medications that we use. Adenosine is a classic medication used. It's a pharmacologic shocking of the heart. What it does, you give it very, very fast. This is one of the only medications I can think of that you give as fast as you can, and you follow it very quickly with IV flushes so that the patient's getting that medicine to their heart all in one bolus. And what it does is it helps to depolarize the heart and reset it. I've got a slide I can show you of that. It's kind of scary when you give adenosine. You'll see why in a minute. Calcium channel blockers. Here we're talking about diltiazem or verapamil. Only these medications are used. The PENS, all the other calcium channel blockers end in PINE. Those can actually cause a reflex tachycardia, so we wouldn't want to use them in this situation. Beta blockers can also be used, and amiodarone can. Amiodarone is used for atrial and ventricular tachycardias. Back to adenosine. Adenosine is a naturally occurring nucleoside. It will decrease the conduction through the AV node, and it decreases the automaticity of the SA node. And that's how it works to slow the heart rate down. It has a very short half-life. That's the good news. A very, very short half-life, about 10 seconds. If adenosine converts the rhythm, then you had a reentry SVT. If it doesn't, then maybe it's because it's A-flutter or AFib. We will treat recurrences of SVT with the adenosine or with some of the longer AV nodal blockers. Diltiazem and the beta blockers actually last a little bit longer. You can cardiovert a patient who is in an SVT if the medications don't work and if they're unstable. We'll talk about cardioverting and defibrillating a little bit later. Definitely, this would be cardioverting. You would not want to defibrillate this rhythm. All right, I mentioned that adenosine physiologically shocks the heart. Here's this patient with SVT, and right about here I pushed 6 milligrams of adenosine, and then I held my breath, because look, and then a long time of nothing. It basically produces some asystole until the half-life wears off. And this is really kind of it feels like a very, very long time. It's not long. And then you can see here that the heart rhythm has resumed at a slower rate. See if I can tell you how long this is. 37, let's see. I gave it, looks like I gave it at 31 seconds, 6 seconds, another 6 seconds. Yeah, each of these represent 6 seconds. So, yeah, it took about 12 seconds for something meaningful to come back, and about 18 seconds before I had a good rhythm established. The heart rate always comes back. That's the good news. But you still hold your breath. All right, atrial flutter. This is another atrial dysrhythmia. People who have atrial flutter, it may be because of coronary artery disease or high blood pressure, long-standing, mitral valve problems, sometimes pulmonary embolism, or reentry phenomena can produce an atrial flutter. It's actually very rare in the normal heart. What happens in atrial flutter is the atrial rate is about 300. And then the ventricular rate is about half that, or another half that, or another half that. So not every one of those flutter impulses get through the AV node. It's not the same as a block. Okay, in a block, in a heart block, physiologically, the AV node should be able to accept the impulse, but it doesn't. In atrial flutter, what's happening is that there's some relative, what do we call that, refractory. There's a relative refractory state in the AV node, and so it's just not ready to accept another impulse due to its refractoriness. So it's not a heart block. So then the ventricular rate can still be quite reasonable because the atrial rate is so fast. So even if only every third beat we're getting it through, the ventricular rate would still be 100. If every fourth beat we're getting through, the ventricular rate would still be 75. So the ventricular rate is fine. See, we got a good picture here in a minute. In atrial flutter, the electrical signal gets trapped in a loop running around the right atrium. Here you can see the loop, causing it to beat, while the ventricle usually beats. Now here, the ability of the AV node to accept the impulse is happening with every other beat. So the ventricular rate here is 150. The abnormal tissue that causes this rhythm is usually located in the right atrium. When you see a tachycardic rhythm that's right at 150, you should think that it could very well be atrial flutter. Now, in this atrial flutter, you have a block. This is a 4-to-1 block. So you have the very normal sawtooth appearance. You know, the atria are contracting, and there's a P wave buried in the T wave too. You know, 1, 2, 3, and there's that fourth one there. So the ventricular rate is 5, 10, 15, 19. It's very close to 75. Divided by 19. Yeah, 78. If it was exactly 5, if it was exactly 20, that would be 75. I wish I had a slide that showed an atrial flutter with a 2-to-1 block. In atrial flutter with a 2-to-1 block, you really can't tell that it's atrial flutter because you have a P, QRST, P, QRST, but what you have is a flutter wave, QRS, flutter wave, QRS, flutter wave, QRS, and it does look a lot like, let me see, it can look a lot like this, okay? Atrial flutter can look a lot like an atrial tachycardia or an SVT, and not until you slow it down can you see that it's a flutter. In atrial fib, the transmission of the impulse in the ventricles is very chaotic. So I didn't say that right. In atrial fibrillation, the impulse in the atria is very chaotic, and so the atria, they fibrillate. Instead of contracting as one unit, these individual cells, just kind of get the impulse on their own. There's a couple of problems with atrial fib. One is the loss of that atrial kick. Remember back from cardiac assessment? 2/3 of the blood that flows into the ventricle flows passively through the valves. And then the final third results from the atria contracting and forcing the remaining blood down to the ventricles. So if I'm in sinus rhythm and I suddenly go into AFib, I'm going to lose that last bit of blood, and that could cause me to have some lightheadedness. I may feel that. Now, if I have chronic atrial fib, there's compensatory stuff going on, and I won't feel that. And then the other really concerning thing is the potential for clot formation. Since these atrias are quivering and they're not contracting, the blood can pool in these little corners, you know, in the corners of the valves, and clots can form. And then the clots can drop into the ventricles and go to either the lungs, or this is your real problem, if they drop into the left ventricle and then are propelled out, you can end up with a stroke. I would say that clots in the right atrium that go to the right ventricle that go to the lungs are probably not going to be noticed because they're very small, but it doesn't take but a very small clot going up to your brain to produce a very, very impressive stroke. This is atrial fibrillation. As you glance at this strip, the first thing you should notice is that it's somewhat irregular. You know, if you just kind of glance over these R to R's, they're not regular. But the hallmark is that you don't have discernible P waves. Rather, you have kind of a squiggly line. Okay? Can't really find a P wave. So there is not a PR interval. Now, the rate of atrial fib can be very slow or very fast. Here is an example of an atrial fibrillation. See the wavy line down here with no discernible P wave? That's probably a T wave there. Okay? And the heart rate is very slow. Now, with atrial fibrillation, the 1500 method wouldn't work because the heart rate, you know, if I took this and measured and divided it into 1500, what I'm assuming is that every beat has this distance. So when every beat is different like this, then you are left with counting the number of complexes in a 6-second strip and multiplying it by 10 to get a heart rate. This is atrial fibrillation with RVR. That's pretty common terminology. We say RVR for rapid ventricular rate. So notice, first of all, notice across the top, very irregular. And then notice that you don't really find a discernible P wave. They're just, you know, kind of all over. Just a very irregular rhythm. So what do we do for atrial fibrillation? And atrial flutter, by the way. The treatments are pretty much the same. IV digoxin will slow conduction through the AV node. So we'll use that if the patient has RVR, rapid ventricular rate. Calcium channel blockers, verapamil, 2.5 to 5 milligrams IV push. We can also use beta blockers in atrial fib to control the heart rate. Diltiazem is another calcium channel blocker. So your two calcium channel blockers are verapamil and diltiazem. The dose on diltiazem is 5 to 10 milligrams an hour. It's going to be in an IV drip. And I mentioned the beta blockers. And then dronedarone is one of the newer medicines that can be used. Converting the rhythm. Well, we consider conversion only if the AFib has been present for less than 40 hours, or if the patient has been anticoagulated for 3 weeks before, and then we still anticoagulate 4 weeks after. Now we can bypass some of that if we do a TEE. So if the patient comes in, they're in atrial fibrillation, and it's creating some problems for them. Maybe their cardiac output's just not good. They just don't feel good, and the physician would really like to cardiovert them. He has two choices. If he doesn't know when it started, he can anticoagulate them for several weeks, for many weeks actually, or they can go to, you know, outpatient whatever procedures. We do them at Christian in the GI lab, believe it or not, but they can be done in any kind of a cardiac situation. The reason they're done in the GI lab is a transesophageal echocardiogram involves part of a GI procedure. You drop a scope into the esophagus. So they can do the TEE to determine if there's any clot in the atria. If there is no clot in the atria, then they can go ahead and cardiovert right then and there. Amiodarone is given as a bolus in a piggyback. It's 150 milligrams over 10 minutes. Repeated as needed, but then we tend to hang a drip. If the patient doesn't convert and stay converted, we go ahead and hang a drip of amiodarone after that. Ibulitide is another antidysrhythmic medication that can be used for AFib. I mentioned cardioversion. Cardioversion, low joules, cardioversion is always synchronized. That's what makes the difference between cardioversion and defibrillation. Generally, it's considered elective. You know, it's not an emergency, so consider IV sedation. If you're going to shock somebody, consider IV sedation. Always have the crash cart available in case things are not so good. Now, if the choice is made to anticoagulate the patient, then they're looking to get an INR of 2 to 3. Some patients will be cardioverted out of their atrial fibrillation only to go back into atrial fibrillation. If the patient does not stay in sinus rhythm, they're going to have to be anticoagulated. It is not safe to walk around in AFib without anticoagulation. Granted, at some point, one has to consider the risk of anticoagulation versus the risk of stroke. So, you know, someone who is 85 years old, we may choose less aggressive anticoagulants than Coumadin if they have AFib. Okay, now we're going to talk about some ventricular dysrhythmias, and we'll start with premature ventricular contractions. Now, in your ventricular dysrhythmias, this is happening below the level of the AV node. So in PVCs, a stimulus originates in an ectopic focus in the ventricle. The QRS occurs early. And because it occurs early, not because it occurs early, because the impulse originates in an ectopic focus in order to depolarize the entire ventricle, it takes a different pathway, and that pathway will then produce a QRS that's wide, distorted, with a large and upside-down T wave. Okay? Because it's early, the beat, the pulse that's associated with that could be weaker than the previous and the subsequent beats. What causes ventricular dysrhythmias? Well, they're often associated with myocardial irritability. When someone has acute myocardial infarction, ventricular dysrhythmias can be pretty common. Also, stimulants like caffeine, aminophylline, used for COPD, epinephrine, those can produce myocardial irritability. Oh, I have some other things up here on the slide too, low potassium, hypoxia. Premature ventricular contractions can be unifocal. That means that they're all originating from the same focus point. When they're unifocal, they all look alike. When they're multifocal, then one PVC looks different from a subsequent PVC. That happens when there are multiple areas of foci or multiple irritable areas in the heart. Bigeminy refers to a ventricular tachycardia that is VTach beat, normal beat, or premature PVC, normal beat, PVC, normal beat. Trigeminy would be every third. Now, premature ventricular contractions are usually benign unless the PVC falls on the T wave of the previous beat. That would be during the relative refractory period of ventricular repolarization. In that refractory period, the relative refractory period, the excitability is enhanced, and so there's a risk of that PVC producing ventricular tachycardia or ventricular fibrillation. All right, this is a PVC. Notice the QRS is widened and the T wave is upside down compared to this beat, you know, P, QRS, Now, there's no P wave associated because this beat originated in the ventricle. So you have QRS, and then the repolarization is also taking a different pathway. This is bigeminy. It's every other beat. So, you know, here's your normal beat. No, sorry, that's my PVC. The normal beat looks pretty sick, actually. So here's the normal beat. This is not a healthy heart, okay? So normal is relative. But the reason I'm calling this normal and this the premature contraction is because there's a compensatory pause and you have another normal beat and then another premature beat. But like I said, the normal beat has a bundle branch block in it. You know, it's not transmitting the impulse like it should. This slide, this is something that I picked up years ago at work. And what this represents or shows you, what you have here, now I know that the it's a little bit hard to see, so let me show you what's supposed to happen. Well, I don't want that. Maybe I'll just do it with a pointer. I was trying to decide whether I was going to write on it or not. Okay, so this one here is the ECG. And if you look closely, you can see P, QRS, T. Now, the tracing has faded over the years. But see the top of the R? Okay, top of the R, top of the R, top of the R. So just imagine that that is your QRS right there. Okay? Now, by the way, there's a little bit of ST segment depression there, because here's my baseline. Anyway, R wave, R wave, R wave, R wave. All right. This is a normal ECG, and here is the arterial line. Remember we said invasive monitoring. Sometimes these patients have a catheter that's inserted in an artery. The transducer is level so that we can decide what zero is, and you can see the beat-to-beat blood pressure here. Okay? Now what's cool about this slide is here is bigeminy. So this is the normal QRS, and I know you can't see that very well, and here's the early beat. And here's the normal beat, and here's the early beat, and here's the normal beat, and here's the early beat. Now let's look up. Look up what happens. There's the normal beat, and that's the blood pressure it produces. Here's the early beat. See how much the blood pressure dropped with that beat? This is the normal beat, and this is the early beat. This is the normal beat, this is the early beat. This here is the art line waveform, and the better blood pressure happens because the ventricle was fuller. The smaller blood pressure happens because the ventricle was not so full. This slide shows frequent PVCs, but what do you think, unifocal or multifocal? These are unifocal. They all look alike. And I could also say that this is trigeminy because every third beat is an early beat. If I had an art line that went with this, I'd have a good blood pressure, a little lower blood pressure. Good blood pressure, a little lower blood pressure. Because these early beats, the heart doesn't have as much time to fill. Now this is something we would call a couplet. There's two early beats right next to each other. That's considered a couplet. This is a premature ventricular contraction, and this is a premature ventricular contraction. Notice they don't look alike, one to the other. So this is an example of multifocal. These are your normal beats here, more normal beats there, and this is multifocal premature ventricular contractions. Okay, ventricular dysrhythmias, ventricular tachycardia. VTach happens when there are 3 or more consecutive PVCs. VTach is potentially life-threatening, especially if it's sustained. Now, if it's 3 beats and then it stops, then you have to ask yourself what's going on with this person's heart. Why is their heart irritable? And you'd like to settle that down before you run into trouble. VTach can be a precursor to VFib, and VFib is not compatible with life. VTach, by the way, can also be pulseless. So if VTach is pulseless, you treat it like it's VFib. Okay? VTach that's pulseless is also not going to be compatible with life. The way this looks, you see no P waves. The QRSs are wider than they should be, and they're quite distorted. The ventricular rate can be anywhere from 100 to 150 beats per minute. The R wave, R to R, can be regular or irregular. And as I mentioned, VTach can have a pulse or it doesn't have a pulse. If it has a pulse and it's sustained, we're still going to treat it rather aggressively because it's not usually well tolerated. Okay then, VTach. This is an example of VTach. You see 3 PVCs here, so that would be VTach, but it abates, and then you can see another PVC here, and I don't know what happens after that. This is also VTach, and this is sustained. If you see this monitor strip, you need to get up and check your patient. Your patient might be sitting in a chair totally oblivious that this is happening, all the way, that would be one end of the spectrum, all the way to unresponsive and pulseless. And you won't know that until you see your patient. If your patient is sitting in the chair and totally oblivious to this, I would say to that patient, I need you to take a deep breath and cough hard to see if you can get that to break. I need you to bear down. You're going to call to get the crash cart in there. You're going to check your patient's blood pressure. This is the patient who's awake. Okay. Now, somewhere in between there, between the patient who's awake and the patient who is, between the patient who's without, impressive symptoms and the patient who is pulseless, could be the patient who's experiencing chest pain, because this can cause a serious drop in cardiac output. They could be experiencing lightheadedness. I just don't feel right. So you check your patient. And you hurry. This is a polymorphic ventricular tachycardia. It is associated with a prolonged QT interval. Now, I don't remember, I know we didn't spend time measuring QTs when we did cardiac assessment. And I'm not going to hold you to a QT, but there are lots and lots of medications that can prolong QT, and that prolonged QT can end up producing a VTach. Now, what this strip shows, just for clarity here, this is the telemetry strip up here, and this is the associated arterial line, okay? So this is the patient's beat-to-beat blood pressure. You can see I have decent blood pressure here. This is an early beat. Here's the PVC, and so that blood pressure was a little lower. And then here's another normal beat. There's the normal beat, and there's the blood pressure that's associated with it. And then it seems to me that this beat fell on that refractory period of the preceding T wave and produced this torsades de pointes. It's a polymorphic, so multiple shapes, ventricular tachycardia. And you can see here, there's no blood pressure to speak of. I mean, okay, so the heart was able to push out, you know, a little bit of blood here, but this is not a blood pressure to speak of. I don't see, you know, I can't see the scale, so I can't tell you what that is. But if we just consider that this might be 80 and this is 120, you can see that there's just not much happening here in the movement of blood. Now, the other thing that torsades de pointes means, I think it's a French word, but it's kind of a twisting. So what you see in torsades is you see this sort of a shape, even top and bottom, although this is not as pronounced as some, but you kind of see this up and down, kind of a rotating movement. A normal QT, just for those of you that would really be interested in knowing that, it should be less than or equal to 0.4 seconds. So that would be like 10 boxes, okay? So QT, from the Q to the end of the T wave. And it is adjusted. The normal QT is adjusted for the heart rate. So a faster heart rate should have a lower QT interval. This patient clearly needs CPR and cardioversion. We also give magnesium for torsades. All right, the interventions. Amiodarone, 150 milligrams over 10 minutes. Lidocaine is an alternate to amiodarone. Years ago, we used lidocaine all the time. Now amiodarone is in vogue, and I hardly ever see lidocaine given. Magnesium sulfate is used if it's torsades, and you give 1 to 2 grams over either 5 minutes to 60 minutes, just kind of depending on your patient. If your patient is in a code, then of course you're going to give it much faster. And then cardioversion and defibrillation. So if your patient has a pulse, you should cardiovert. If your patient does not have a pulse, you defibrillate. In ventricular fibrillation, this rhythm is not compatible with life. You have chaotic transmission of the impulses throughout the ventricles, so each little muscle cell is acting like its own little thing instead of all the muscle cells depolarizing to allow the ventricle to contract and propel blood out. So the ventricles just quiver. There's no QRS, consequently there's no pulse. If there's no pulse and no QRS, obviously there's no cardiac output, patient stops breathing, they may have a seizure. This is a fatal rhythm unless we get it converted. Here you go. This is VFib following an R on T. So you can see here this is an SVT. It could be VTAC. It's kind of hard to tell. The wider the complex, the more likely it is to be VTAC. But then here, the next beat fell on that refractory and put the patient into VFib. These are no QRSs. That is kind of a coarse VFib, though. Coarse VFib, that's still pretty coarse VFib. Coarse means there is more electrical activity that you can grab onto. Coarse is better than fine. Okay, I guess I don't have a real fine one. In ventricular fibrillation, your priority intervention is going to be to defibrillate the patient. You're going to call a code. You're going to start CPR. As soon as your defibrillator is available, you're going to get that defibrillator hooked up. Do not hold up defibrillation to continue CPR. Defibrillation is your priority intervention. If your patient is already hooked up to the defibrillator pads and they go into VFib, you shock them. The equipment that we have is biphasic or monophasic, and most of it's biphasic. Biphasic sends the electricity in both directions, where monophasic goes from one direction to the other. The biphasic that you're supposed to use the joules on will be device specific. If you don't know, for VFib, you just use 200 joules. The AEDs that you can pick up, they will be device specific, but you don't set that. The AEDs are already preset. All you have to do is push a button, follow directions and push a button. Monophasics, you will defibrillate at the max joules, which is 360. Then you do 5 cycles of CPR. So even if you defibrillate and it looks like you got a rhythm coming back, you do 5 cycles of CPR to help that heart move blood. Then you check your rhythm. Then if you're still in VFib, you shock again, 5 cycles of CPR. Then you consider meds. This is the ACLS algorithm for VFib. You shock, 5 cycles of CPR, shock again, 5 cycles of CPR, and then start meds. And the first medication in a pulseless situation is always going to be epinephrine. Here you have the paddles. We don't use paddles at Christian anymore. I'm sure there are places that use paddles. We put the pads on the patient. One of the things to keep in mind is that using these paddles makes it very obvious what's happening. When you put pads on a patient, you are going to push the defibrillator button from a machine off in the corner. When you put these pads on, you defibrillate with a button that's actually on these paddles, so everybody can see, you know, and if I'm the one holding these paddles down, I check to see that everybody's clear, and then I defibrillate. With the patches, pushing the defibrillator button happens up by the machine, so you have to be extremely considerate of your colleagues that might be still touching the bed, because you can give them quite a jolt and it can be dangerous. Always call all clear before you push that button, and not just call all clear, but do a visual check to make sure that indeed nobody's touching the bed or the patient. More concepts coming. After we have shocked the patient, or while we're waiting for our equipment to get there, we're going to do CPR, airway management, and the ACLS protocol. The first medication given in a pulseless patient is epinephrine 1 milligram IV. You can substitute vasopressin 40 units for either the first or the second dose of epi. After you give the epi, you cycle that with CPR. Then you shock the patient again if need be. Then you can give either vaso or epi for the second dose, but you only do the vaso once. At some point in the algorithm, we can add antidysrhythmics if the rhythm is not if the rhythm is not defibrillated, if it's not corrected. Then the first drug of choice is amiodarone. We give 300 milligrams IV. We give it IV push, and then we give, in subsequent dosing, as we work through the algorithm, we'll give another 150 milligrams IV push if the rhythm hasn't corrected. If amiodarone doesn't do the trick, then we add lidocaine, and lidocaine is based on the patient's weight. If we do lidocaine again, it would be half that initial dose, and we can give lidocaine up to 3 milligrams a kilogram. Seems to me that there was something else I was going to say about this. Maybe it'll come to me. Torsades, I've mentioned, gets mag sulfate. Defibrillate between meds. Continue CPR for 5 cycles while your defibrillator is charging. And even when you have a restored rhythm, you're still going to do 1 full round of CPR to help that. Oh, I know. On the epinephrine, I said you can use vasopressin for either the first or the second dose of pressor. Then, after that, you can give epinephrine every 3 to 5 minutes throughout the code until either the patient has a stable rhythm or the code is called and the patient has died. Now, for patients who have had VTach, VFib arrest, or who are at risk for, they're going to get implanted cardioverter defibrillators. Here's the indications: cardiac arrest survivors, patients who have recurrent sustained ventricular tachycardia, or patients at risk for sudden cardiac death. Remember, patients at risk for sudden cardiac death are those that have ejection fractions of less than 30%. The ICDs significantly decrease cardiac mortality rates and also decrease the need for antidysrhythmic meds. And the antidysrhythmic meds do have side effects. So what an ICD does is it monitors heart rate and rhythm. It will identify VTach or VFib, and it will deliver a shock to the heart muscle. Now, it's only 25 joules because the wires are right on the heart. It doesn't have to get through the impedance of the chest wall. There is a table in your book regarding teaching for the ICD. My notes say that it's table 36-9. I didn't write down what edition that was, so I think it's the 8th edition, table 36-9. If not, then you just look for patient teaching for ICDs. Okay, let's see if I can switch over now to this all right. Hopefully this works and you can see. Here's a patient. His heart is beating. Atrias, ventricles, atrias, ventricles. This is the ICD. This is the wires, atrial wire, ventricular wire. Now he's going into VFib. Notice no atrial contraction, no ventricular contraction. The atrias are contracting. The impulse fires, depolarizes everything, and now you have things back in sync. All right, let me play that again. Atria, ventricle, everything's going like it's supposed to. The atrias are contracting, the ventricle's contracting. There's the wires, atrial, ventricular. Suddenly, there's no cardiac output. The atrias are contracting, but unless the ventricles contract, the blood does not move. Now the impulse is fired, the ventricles are depolarized, and they're able to start back up again. That is the goal. All right, now, how do I get out of this? Well, it may take me a minute. Okay, out of this, and I don't know what you can see right now. All right, back to the classroom. Yep, that's what I showed you. It wouldn't work in here because it's just a picture of that. Now this is an example of a chest x-ray. Here's a chest x-ray, and the patient has an ICD and a pacemaker, and why in the world they have both, I don't know. Normally they take out the old one and they use the same pocket, but you can see what that looks like. All right, pulseless electrical activity has a very poor prognosis unless the cause is very quickly identified and removed. In PEA, the impulses are transmitted, but cardiac muscle contraction is not effective. So your QRS can look like whatever. You have a pattern, but you have no pulse. And in all fairness, the pattern will degenerate to something that is, pretty yucky looking too. But initially, you do have some kind of a monitor pattern, but no pulse. So anytime you see something up there on telly in a code, and someone has checked a pulse, we call it PEA. Some things that can cause PEA, cardiac tamponade. Imagine that I've got blood in the pericardial sac and it's pressing on the heart so that the heart cannot relax and fill. The electrical conduction system is still working, but there's no blood to be pumped out. So the treatment for that, of course, would be a pericardiocentesis, where they stick a needle into the sac and draw the blood off so that the heart can relax and fill. The patient who's very hypovolemic, if I'm bleeding out, then eventually my heart is not going to have blood in it to pump around, and my heart rate, of course, is very tachycardic. Tension pneumothorax, a massive myocardial infarction. Now, truly, we do mean massive at this point. Say a myocardial infarction that has just damaged the whole anterior, lateral septum. If you have a block on the left main that becomes completely occluded, they call that the widowmaker. If it takes out the LAD and the circumflex and the whole ventricle is ischemic and it doesn't pump, that can certainly cause PEA. Metabolic acidosis, too much or too little potassium, some drug overdoses, overwhelming hypoxia, pulmonary embolus. What we're going to do here is CPR, correct cause. Without that, the patient's likely not going to do well. Okay. Now, cardioversion and defibrillation. Cardioversion is also called synchronized cardioversion. Okay? Synchronized cardioversion and defibrillation is accomplished by sending a DC current through the heart sufficient to depolarize the myocardial cells, so that the repolarization that follows allows the SA node to resume its pacemaker role. Okay? So the goal is for that current to depolarize the myocardial cells to allow for a normal repolarization, and then the SA node to resume its pacemaker role. Let's look at defibrillation first. Defibrillation, here the patient is pulseless. We're going to defibrillate only two rhythms. We defibrillate ventricular fibrillation and pulseless ventricular tachycardia. With the biphasic, we do 150 to 200 joules. With the monophasic, we do maximum. You want to make sure that the synchronizer switch is off. I'll explain that in a bit. And you continue CPR and the ACLS protocol. Okay, synchronizer switch off. Now, in cardioversion, the patient has a pulse, but they may be unstable. So here are some things that get cardioverted: ventricular tachycardia, SVT, and AFib. We go much lower on the joules. The synchronizer switch has to be on, and what the synchronizer switch does is it identifies the R wave of the QRS complex and delivers the DC current on that R wave. And what we're trying to do is avoid the QRS. I'm sorry, not the QRS. I'm sorry. Because, of course, the R wave is part of the QRS. What we're trying to avoid is the T wave, and we certainly don't want to deliver a DC shock on the T wave. That could put the patient in an even worse rhythm. So, synchronizer on will flag the R waves so that the impulse that is going to produce the depolarization does not occur on the T wave. Now, if you have the synchronizer switch on inadvertently and you need to defibrillate the patient, well, in VFib, there are no R waves to flag. So let's say you have the paddles in your hand and you push the button. Nothing happens if the sync button is on because it's looking for R waves. And the reason we don't sync tachycardia, ventricular tachycardia that's pulseless, is because that patient's having a serious enough problem that we want to give them max joules, and we don't care where it hits because we need to get that reversed. So at least the synchronizer button would work if the defibrillator recognizes the VTAC with the R waves, and it should. But the rule is pulseless, defibrillation, pulse, cardiovert. And the difference between these two things is the sync button. Sync button on is cardioverting. Sync button off is defibrillation. In cardioversion, you always want to consider IV sedation. We may not be able to give the patient IV sedation. They might just be unstable enough, and then it's a matter of, you know, the patient's lightheaded, they're hypotensive, and they look really, really bad. You don't want to give them sedation and lower their blood pressure more. It's just, I'm sorry, ma'am, you're going to feel this. I've got to, we've got to shock you to get that heart out of that rhythm. The operator of the defibrillator cardioverter is always going to look and call all clear to make sure that no one is touching the patient at the time of shock discharge. All right, a little bit about pacemakers, and I think that'll be all that we have to do, just a little bit about pacemakers. Okay, pacemakers. These are electronic devices, and they are used in place of the SA node, or they're used to conduct the impulse across the AV node if there's a block in the AV node that isn't allowing that to happen naturally. So why do we use pacemakers? Well, we can use them temporarily for any symptomatic bradycardia that wasn't responding to medicine. They're often always available for open heart surgery. The patient will come back with pacer wires sticking out of their chest in case we need to hook up a pacemaker. The inferior MIs and the anterior MIs sometimes have difficulty in the immediate MI time, and so we may need a pacemaker. I can say that in the anterior MIs, they might progress to where they actually need a permanent pacemaker. The inferior MIs, the conduction disturbances tend to resolve once the heart gets used to the changes. Okay, permanent pacemakers. Permanent pacemakers are needed for people who have SA node dysfunction. Sick-sinus syndrome is an example of the SA node dysfunction. Second degree, type 2, that's the Mobitz type 2, or the complete heart block, which is your third degree. So remember, there were 4 heart blocks. The first 2 are pretty benign. The second 2 always need pacemakers. And then anybody who has a symptomatic brady-dysrhythmia that continues to create a problem for them. Okay, a final reason for pacemakers is cardiac resynchronization therapy. That's something completely different than getting an impulse to conduct through heart conduction system. We'll say more about that when we talk about heart failure, but since I'm recording and don't have the same, constraints and pressures for time, I'll go ahead and introduce it a little bit now. One of the things that happens in heart failure is that there often develops a bundle branch block. Namely, you got the right bundle branch, you got the left bundle branch, and a block develops in one of those bundle branches, and so the impulse doesn't just jet down 2 bundle branches very quickly, rather it jets down 1 bundle branch quickly, and then the other bundle branch, it finds that block, and then it has to kind of go the long way around. And in most, like if I had a bundle branch block, it probably wouldn't be significant, that slight little difference. But if I'm a patient with heart failure and my heart already has trouble pumping blood out, the patient can gain impressive improvement in heart function by inserting a special pacemaker. They're called biventricular pacemaker, BiV. So you have a lead in the atria, and then you have one lead going into the right ventricle, that's on the inside of the heart, and then they thread another lead along the outside of the left heart, and they do it so that the pacemaker, the right lead and the left lead, get the impulse at the same time to allow the right side of the heart and the left side of the heart to contract exactly at the same time, putting pressure on the septum and acting very synchronously. I have videos of the dyssynchrony that happens in heart failure and the resynchrony that happens with a BiV pacemaker when we do heart failure. So a patient who gets a BiV pacemaker often doesn't have to have a heart block. It's also not uncommon at all for someone in particular who gets a BiV pacemaker to get an ICD BiV pacemaker all in one. Namely, you know, people who have heart failure often have that ejection fraction of less than 30%, so they're at risk for sudden death. So they need the ICD, and then they can add the BiV pacemaker for cardiac resynchronization and actually improve their heart function. So that's what I'm going to say about cardiac resynchronization. Save that in your little old noggins for when we talk about heart failure. I'm sure I'll be repeating it, but it probably doesn't hurt to hear this stuff more than once. So back to pacemakers, temporary, permanent, and what they do ordinarily. Starting with the transcutaneous pacemakers. Transcutaneous means across the skin. They are used for temporary pacing. We use a pad at the apex and a pad to the back. So apex and back. Some models can be used to defibrillate or cardiovert. So if I've got this patient with these pacemaker pads, you know, the crash carts that we use, I can use these as a pacemaker. I can also flip them over and flip the little switch and use the same setup to defibrillate. You need to keep in mind that this is contracting, this is going through the skin, so it will cause painful muscle contractions. The goal is to get the impulse to the heart so that the heart does its normal thing. So we give pain medication and some sedation, if at all possible, to deal with that. And then if it's going to be for any length of time or once things get stabilized, then we do a transvenous pacemaker. And a transvenous pacemaker is inserted through a central line into the right ventricle. And generally what happens, like this picture here only shows like a pacemaker wire being threaded through here, through the internal jugular and here through the basilic. But actually what we do is we put an introducer, which is a big IV type thing, into one of these central vessels, and through that we thread the pacemaker wire. And then permanent pacemakers, demand pacemakers. All of our pacemakers nowadays are demand pacemakers. Okay? What a demand pacemaker does is it fires when it detects a lapse in the intrinsic rhythm. The olden days, we used to have fixed pacemakers. They weren't so smart, and they would fire at a preset rate regardless of what was going on in the heart. So sometimes you'd have the pacemaker firing when the heart would have liked to. Now, with the demand pacemakers, they have the ability to sense what's going on and to respond appropriately. Very, very, very smart technology. Way beyond me. Pacing modes. Pacemakers can be ventricular pacemakers. They can be biventricular pacemakers, as for the heart failure. They can be atrial pacemakers. Most of the pacemakers that you will see will be dual pacemakers. There's a 3-letter system that's used. So there's a chamber that will pace, or that will be paced. There's a chamber that will be sensed. And then the 3rd letter is the pacemaker's response. Now, some examples of this: the chamber that's paced, nowadays we use dual pacing, so it would be D. The chamber that's sensed is often D. So dual paced, dual sensed, that means each chamber is sensing what's going on. And then the typical response is to inhibit, so that when it senses something going on, it inhibits the pacemaker. When it doesn't sense, and this is all set in there with algorithms, and it's based on milliseconds of time. If it doesn't sense electrical activity within a certain amount of time, then it will go ahead and allow the pacemaker to pace. So if I've got a pacemaker, atrial, ventricular, dual, the atria wire will sense what's going on in the atria, okay? And if the impulse is coming out of the SA node like it should, the wire up here does nothing. That impulse gets to the AV node. Does it make it through? If it makes it through, then the wire in the ventricle does nothing. Okay, so the pacemaker was working in that it sensed what the heart was doing and chose to do nothing. Okay, good job, pacemaker. Here's another example. The pacemaker in the atria is sensing what's going on, and it does not sense any activity. It waits a certain amount of time. It's all preset. Still no activity. It fires in the atria to depolarize the atria. Okay, the impulse that was triggered by that pacemaker in the atria, the pacer wire in the atria, is now at the level of the AV node, and now the ventricular wire is sensing, and it's paying attention. Is an impulse coming? Is an impulse coming? Yes? Well, then it inhibits electrical activity. But if it doesn't come through the AV node, then the ventricular wire will initiate an impulse to allow the ventricles to be paced. Pacemaker, it's placed in a pocket under the skin here, and then the vessel is accessed. A lead remains in the right atrium, another lead goes to the left atrium. I think I mentioned in class that these leads have little barbs on them so that they actually catch into the heart muscle. This is a paced rhythm. These are just pacemaker spikes, and you can have your monitor to identify it for you. Your monitors can draw these little lines. That just means that the pacemaker initiated that impulse. So that's a pacemaker rhythm. This is a demand pacemaker rhythm. Normal beat, although I will say I think the P wave's upside down. So maybe it's a junctional rhythm that's going backwards, but that's okay. You don't need to deal with that, okay? Anyway, here's the P wave, QRST, P wave, QRST, all on. And then here in the atria, the impulse, nothing happened. So the pacemaker fired in order to allow the ventricle to get its impulse. So who gets pacemakers? Well, temporary pacemakers. I feel like I've said this already, but maybe it's in here for me to say it again. Symptomatic bradiodysrhythmias, not responding to medicines. We use pacemaking for prophylactic open heart surgery. That's not open here surgery, it's open heart. Inferior and anterior MIs. And then permanent pacemakers, I know that I've mentioned all these already. And then any symptomatic bradycardia. So who gets symptomatic bradycardias? What are we talking about here? Well, people who have autoimmune or fibrosing or sclerosing disorders of the conduction system. And then atrial fibrillation with a very slow ventricular response may also need a pacemaker. And a pacemaker does not correct the atrial fibrillation. It just gets an impulse through the ventricles more often. And then I mentioned cardiac resynchronization therapy. Okay, this strip here shows you a bradycardic patient. Now you cannot see on this monitor that he has signs of hypoperfusion. That would be your physical assessment, your vital signs, your lightheadedness, low urine output, whatever. But this is a bradycardic patient with signs of hypoperfusion. Clearly that's a symptom that would be symptomatic bradycardia. The pacemaker is turned on. You can see that it's flagging the R waves. It's sensing. Okay, and then what we do is we set the pacemaker rate, and we increase the current to the patient until it captures. So here's the pacemaker. We set the rate, but it's not capturing yet. See, it's not capturing. So we increase the current on the pacemaker until there's a pacer spike, and now it captured. The pacemaker spike captured, and that's the patient's intrinsic rate, and the pacemaker spike captured. So we increase the current to an effective level that causes ventricular capture. Some problems with pacemakers, well, they can fail to sense, and if that happens, then what will happen is the pacemaker will fire inappropriately. It doesn't recognize that the heart's actually doing something, and it fires when it shouldn't. A couple of causes: lead displacement or damage, or sometimes battery failure. Here's an example of a failure to sense. See, the heart was doing what it needed to do, and it didn't wait long enough. It just, threw an impulse in there. It doesn't recognize the normal beat. Failure to capture. In failure to capture, the electrical charge is not strong enough to produce the contraction. So you see a pacemaker spike, but you don't see the P or the QRS that should go with it. Again, lead damage, displacement, battery failure. Sometimes fibrosis at the electrical tip can cause that. Failure to capture. I know I have a strip of that. A couple of other complications would be infection. And patient teaching is not a complication, but you need to be aware of the patient teaching. My notes say table 3612. Here's a slide of failure to capture. See? There's the pacemaker spike, but it didn't grab it. Now this one grabbed. Okay, so that would need to be looked at to figure out what's going on. All right, that is it. Recording stopped. And we will pick up with some of this stuff later in class.